Hi, I'm Jack Caldwell. I work at Virginia Equine Imaging, and today I'll be talking about the Asto CT and how we use it in private practice and present some clinical cases that we've seen lately. A little about our practice. We're predominantly lameness and performance horse medicine, and we mostly see sport horses. We have digital radiographs, both portable machines and an overhead 1000 MA generator, as well as ultrasound, bone scan, and standing hallmark MRI, which is off-site. Most recently, we have installed the Asto standing CT. The question really is, before we put the CT in, is would fan beam CT be applicable for everyday use in performance horse medicine? And the answer so far has been absolutely. Additionally, we're working with nearby surgeons and surgical facilities for surgical planning, as well as other referring veterinarians, and trying to encourage them to use this technology as well. This first case here, it's a 4-star jumper, 14-year-old Dutch warm blood gelding, presenting for a chronic left front lameness. He'd been treated as if he had an abscess for quite a bit of time. It was a 3/5 left front lameness that mildly improved after a PDN, largely improved after an abaxial nerve block, and completely improved after a low 4-point nerve block. There was no switch to the opposite leg. We recommended MRI of the left front foot, pastern, and fetlock. The findings, we found arthritic changes in both the coffin joint and pastern joint, as well as suspensory branch changes up at the level of the fetlock. Importantly, also, what was noted was that there was suspected, not confirmed, but suspected mild to moderate medial joint narrowing. So the horse was treated. We treated the left front coffin joint, the pastern joint. We treated the suspensory branches both with shockwave therapy and eventually laser therapy, and gave the horse IV bisphosphonates as well. At a 30-day recheck, the horse had actually worsened. The horse was about a 4 out of 5 at this point. At that point in time, I did an intra-articular coffin joint block. There was no improvement after 5 minutes. Significant improvement after 10 minutes, and then waning improvement thereafter. After that, the horse did again resolve, this time with a abaxial nerve block instead of a low 4-point nerve block. At that point, we had recommended CT of the distal limb with contrast in the coffin joint. Here's an image pre-contrast. You can see there's a bit of that kind of suspicious mild to moderate joint narrowing medially of the left front, which is shown on actually the right side of the screen here. And then here, it might be a bit challenging to see, but there is contrast actually in the left front coffin joint, and on the lateral aspect, it is not filling in inappropriately, but medially, there is fill into the area where there should be cartilage. So our findings. Not only was there marked coffin joint changes with synovitis, but there was also diffuse cartilage thinning, widespread medial full thickness cartilage erosion. At that point in time, we were really just trying to salvage the horse and make it comfortable at the walk. We weren't able to do so and eventually elected for euthanasia. But the point being here is that intra-articular contrast along with CT examination was a better determinant of the pathology that was present in this horse over low field MRI. A hind limb case is a 15-year-old warm blood mare used for dressage. The history was a 1.5/5 right hind lameness, worse when circling to the left. It had been treated previously with steroid injections of the DIT and TMT, and additionally had had a bilateral hind proximal suspensory neurectomy. When we saw the horse, the lameness only mildly improved after direct infiltration of the proximal suspensory ligament, but the mare did block almost entirely to a tibial nerve block. Here you can see the proximal suspensory ligament fiber disruption, as well as the primary proximal suspensory ligament enthesopathy. Given that the horse had already had a neurectomy and that there was only mild improvement following this, we decided that it was likely not the primary source of this horse's lameness. Instead, what we found is a distal medial talus subchondral defect bordered by sclerosis. This was not previously seen on radiographs, and despite even going back to the radiographs, it's really challenging to try to pick that up. So, we went ahead and actually we ended up treating the talocalcaneal joint repeatedly, and we were able to improve this horse. Just to highlight here that the increased sensitivity over radiographs in detecting pathology. Moving on to a front limb. It was an 11-year-old Hanoverian gelding presenting with a 3/5 lameness back in 2021. So this horse was actually seen by my associate a few years back. The right front lameness resolved with a PDN, switched to a left front, which then resolved the lameness fully. And the PDN resolved the lameness fully. And an MRI was recommended at that time. The findings were basically an extensive deep digital flexor tendon tear from P2 down to its insertion. Fewer findings in the left front limb. A recheck MRI was performed in 2022, so a year later, following a year of rest. What was noted was a progressive DDF tear from P2 down to the navicular bone, but the insertional tear had improved. There was a new smaller tear in the mid-pastern lobe, and the left front remained unchanged. The gelding continued to rehab and progress in work over the next 3 years. Intermittently, it was exhibiting mild or mild to moderate right front lameness, and the horse was basically held together with PRP injections and bisphosphonate therapy. In 2025, the gelding exhibited a more pronounced 3/5 right front lameness, and we elected for CT evaluation. Here you can see the extent of the deep digital flexor tendon lesion. And then you can see not only is the lobe distorted, but also you can see sort of the core lesion there tracking down the leg to the level of the navicular bone there. The findings were that there was a moderately progressive DDF tear from mid-P1, so now not from P2, but from mid-P1, to the distal aspect of the navicular bone. The suprasesamoidean component is now a full thickness parasagittal tear, and there's also new findings as well. So this was really to highlight the potential utility of fan beam CT as a recheck modality for low field MRI, and sometimes it can be the primary modality. Oftentimes it is. So kind of a quick summation as far as private practice practicality. The horses tolerate it well. It takes far less time than running the MRI. For us, our MRI is off-site, so we don't have to take the horse to a new location. The clients appreciate it. The cost is, I think, significantly less than what it would cost for an MRI, and you get a larger area of interest. So instead of a few $1,000s for a bilateral MRI of both front feet, where you're getting from mid-pastern down to the ground, we're getting mid-cannon down to the ground, so you're getting suspensory branches and more fetlock information, and we all know that blocks travel. So I think that this is becoming an important piece of imaging horses after we've blocked them to an area. And then we appreciate it too, obviously, because we're finding more things. It's more sensitive than just our ultrasound or our radiographs alone. So we're finding a lot of uses for it, and additionally, the referring veterinarians in our area are finding uses for it. I try to be accommodating. We accept horses in, do the imaging, put them back on the trailer, send them on their way, and send them a report, hopefully 24 to 48 hours later, and then those horses are treated by their respective veterinarians there. So just trying to bring the technology to the area, because we think we get to diagnostics, or get to a diagnosis rather, faster and for potentially considerably less money. And the horses are treated more quickly, and clients are happier. This is a neck case. It's a 9-year-old Irish sport horse gelding used for eventing. The history is that this horse had significant right front lameness that was only evident after the horse was laying down for a period of time. So this was a challenge for the referring veterinarian because each time the client was saying, oh, the horse is lame, I see it take 3, 4, 5 lame steps after it gets up, I'm really worried about it. The veterinarian would come out to the farm and the horse jogged up beautifully, flexions were normal, and there was nowhere to start blocking because the horse wasn't off. So it was actually decided that it might be smart to get some more information about the neck. Here you can see narrowing, well, first enlargement of the articular process and then cranial interference. So basically nerve root impingement. And this horse ended up going to surgery for a foraminotomy and is currently doing quite well, and the issue has resolved. So this was really just to highlight the fact that we can get down to C6-7 in a standing sedated horse. I find that in the horses that we've done so far, we're getting down to C6-7 in about 80 to 85% of those horses. I think that getting down to C6-7 and looking at the base of the neck is really more about patient positioning than anything, less so about the horse's conformation. We've done horses as big as 18.3 down to little ponies and Icelandic horses and everything in between. And we are finding, again, it's less so about conformation and more so about how we position the patient. And I will say in the 15 to 20% where we're not getting all the way down to the neck, I think it's less so their conformation and more so patient compliance. So some horses are just challenging to get into the exact right plane. Sometimes they're neurologic or ataxic and have a difficult time standing in a certain way, sometimes the way that we want them to stand, and that seems to be the main limitation with getting all the way down to the base of the neck. An upper forelimb case is a 14-year-old warm blood cross gelding used for eventing. Histories of an acute left front lameness. It was referred for full body nuclear scintigraphy, and then we followed up with additional diagnostics. So here there's a dorsal and a flexed lateral view. The flexed lateral view helped to differentiate if the uptake was at the distal or proximal carpal row. We determined that it was distal. Here are survey radiographs of the area, and there is actually kind of a one post-op radiograph there as well. But even on the skyline view, it's challenging to see that there is sort of a discrete fracture in that area. It's nice and easy with 2 arrows pointing directly at it, but I think what's remarkable is, if I go to the next slide here, is on CT, that same fracture really highlights quite well. So with demineralization, the sclerosis surrounding it, and then the fracture line, it just becomes more apparent from across the room practically. So I think CT did a nice job here and made surgical planning quite a bit easier. This was a 15-year-old thoroughbred gelding. It was referred for a full-body nuclear scintigraphy due to a bilateral hind limb lameness and neck stiffness. When the gelding was dropped off, it was noted to have a real reluctancy to pull his head from side to side or lift it up and down. He was kind of in a bad way. He additionally had a history of guttural pouch mycosis on the left side that was 3 years prior. They did the coil embolization surgery in the left carotid artery and figured that basically they had resolved the fungal infection at that time. On nuclear scintigraphy, there was intense focal radiopharmaceutical uptake appreciated at the pole and proximal C1. So we elected to basically do a head and partial neck CT of the area. Here what you can see is basically the left side of the back of the skull is gone. You're actually able to see the brain from outside of the skull. So there is areas also of proximal C1 that were sort of mottled and chewed up, and many spiculated areas at the back of the skull as well. The diagnosis was osteomyelitis and meningitis, likely fungal in origin. And this horse was taken to a pathologist, and it was determined that it was actually a fungal infection. And it's something that we're currently doing a paper on now to to make it known that this might be a sequela of a former fungal infection that was thought to have resolved years prior. So again, nuclear scintigraphy mixed with our CT just gives us a complete picture of what's going on in the area. Very complementary. This is a 5-year-old thoroughbred gelding referred for a head CT due to traumatic injury to the left side of the head. The horse was reportedly turned out with a friend, and apparently they were best friends, and that best friend didn't wear hind shoes. But the skull fracture along the side of his head, just rostral to the orbits, kind of said otherwise. So it was awfully hoof-shaped in appearance. So it was suspected that these two kind of got after one another. So again, we can see soft tissue swelling just over the eye there, as well as the depression fracture, the comminuted fracture of that skull. And this horse was sent to surgery, where multiple plates were placed, and then the horse recovered, came back to us, and we did recheck CT to check the placement of the plates and how well the surgery went. So just to highlight how relevant it is for surgical operation before going in to do a reconstruction like this, and the benefit of being able to look at the post-op version. 25-year-old thoroughbred gelding was used for eventing, had a severe right front lameness of several weeks duration. Again, I think this one had been treated as an abscess. Radiographs show lucent area at the distal aspect of P3, and to better characterize exactly what was going on there, it was sent to us for CT. What we found was a keratoma. So there was a soft tissue mass with adjacent bony resorption. And the nice thing about this is that we get a complete picture of what's going on. The horse may have been abscessing, but from the area, but it was likely a sequela to the keratoma that was present, and this would need surgical debridement. So it's just an enhanced look at what our radiographs are probably underappreciating. Another head CT. So heads probably constitute 25 to 33% or so of our referred cases. I've heard from a surgeon in the area that he would be basically silly to do head surgery without a CT prior. This particular one, this is a pretty common presentation. We see right-sided or unilateral purulent nasal discharge that has been refractory to antibiotic therapy. Upper airway endoscopy is unremarkable. The diagnosis was periodontal disease and suspected periapical abscess with associated right sinusitis. The nice thing about CT versus skull radiographs they're challenging to read, I think, for anybody. I don't know many people who enjoy doing it. The CT is, on the other hand, is straightforward, or seemingly straightforward from a private practitioner's standpoint, not from a radiology standpoint, but it's easy to see, a yin and yang here of air on one side in the sinuses and fluid on the other side. So it's quite straightforward in some of these cases. Again, so just superior imaging. We've been using this a ton. The Asto CT, I think, fits our practice well. It's quick, it's easy, and we're getting good images and getting diagnoses. So, thank you.